Hi, I'm Dr. Randall Thomas from Orthopedic Foot and Ankle Center. Today we're going to talk about an all too common foot condition, hammertoes. Hammertoes are a common condition that can present in patients in a variety of ways. There are usually a flexion contracture, or the foot and the toes going down. Usually happens in the lesser toes, not as much in the big toe, but it can occur there. It can elevate at the joint where the long bone meets the toe, and this is usually a muscle-tendon imbalance. It can have to do with your foot structure, previous injuries, but can be quite painful for patients, make it difficult to get into shoes. And there's differences between hammer toes, mallet toes, and claw toes, and this is a common question that patients ask and we can review in the office. Symptoms are typically pain. This is related to rubbing in the shoes, elevation of the toes, or even seeing breakdown of the skin. We can see a lot of corns and calluses from rubbing, from the contracture of the toes pushing in the space in the shoes. However, it can also lead to ulcers and wounds in patients that don't have feeling, such as diabetics with neuropathy. So this is a common condition of difficulty fitting in shoes, seeing cosmetically the toes contract, and having a lot of pain with this. It can be progressive, meaning it's not going to go back to being straight, the toe, but I don't know how quickly it's going to progress. Every patient is different, from very mild contractures that you can reduce, meaning the toe is bent, but you can just push it straight, to rigid contractures where it's bent and you can't budge it at the joints. The causes of hammertoes are typically related to muscle imbalance. A lot of times they have a lot of tightness on the calf. Those muscles go down as tendons all the way to the tips of the toes and lead to contracture of the toes. You can also see in some conditions, particularly ones with neuropathy, where you lose some of the muscle function at the bottom of the foot and the toes contract. This has been categorized in the literature in a few different ways, having to do with your foot structure. If you have a high arch foot, the tendons on the top overpower and contract it. If you have more of a lower arch or a flat foot, they tend to pull the toes out of position, and they can vary in multiple planes. They can vary top to bottom, side to side, and in rotation. There's also other conditions, such as traumatic conditions, that can cause this. This is typically diagnosed by physical exam and on x-rays. Fairly evident because it's one of the most common conditions we see. But one of the things we need to determine is what's the main factor leading to the contracture. Is it top to bottom, side to side, or rotation? Is there another reason this is happening, some other structural problem with the foot or the lower leg? You don't want to get blinded to just looking at the hammer toe. You want to know the reason why it's occurring, so you have the best option to treat it both conservatively and surgically. So the treatments start out with conservative care, higher toe box shoes, wider toe box shoes. There's ways to do taping and strapping of the toes down, padding in the shoes, trying to modify custom shoes if needed for patients. Sometimes, but more rare, we could do injections of steroid for pain control, anti-inflammatories, topicals. If the non-operative treatment doesn't work, including using splints at night, trying even Botox injections have been done in the literature. There's a host of treatments you could try, but if it doesn't work and it progresses, then it's usually a surgical procedure. The interesting thing is the surgery procedures vary. There are lots of ways to treat hammertoes. Unfortunately, this has been fraught with patients not always being happy with the outcomes. So it also commonly can lead to revisional surgeries. With revisional surgeries in toes, there's not a lot of anatomy there to protect the nerves and the blood vessels, and this can be high risk to patients ending up with chronic pain, chronic deformity, even things such as amputation. With the surgical procedure, there's essentially twofold that we address for the hammertoe itself. One is cutting out the bone that's prominent and balancing the tendons, letting the joint continue to move. And the other, that's more tried and true, is fusing the toe. So typically with the hammertoes, eventually the toes don't move very well anyway. So we straighten the toes and hold them in position and get the two knuckles or joints in the toes to grow together into one block of bone. You can still move at the joint where the toe meets the foot, but would not have the ability to contract the toes. And that really decreases the risk of recurrence, actually takes pain down. But if we can, we'll try to save the joints and keep that mobility there. There are a host of implants, screws, different implants for fusions that can be used. There seems to be a lot on the market coming out. But the traditional surgeries work very well. Rarely do we have to anymore leave exposed pins. That's kind of a more barbaric in the past approach that really has scared patients and puts them at more risk for infection and complications. So most of the implants are internal if implants are needed. Again, if there's any other issue with the foot driving the hammer-toe, we want to address that at the same time, as that takes down our recurrence risk. The recovery process can vary for individual patients and depending on what surgery we employ. A lot of these surgeries, the patients can walk that day in either a boot or a post-operative shoe. Typically about 6 weeks till they can get back in their regular shoe gear, more supportive athletic shoes. Getting into more dress or fashion shoes around 12 weeks. A lot of times we'll do at-home therapy, give the patients a packet of therapy to do. Sometimes they go to physical therapy. It can include a lot of rest, ice, compression, typical post-operative course. Most patients are off of pain medication within a day or two. They're used to having pain in their toes and they do very well after the procedure. Beyond that, there's some limitations in getting into water, swimming, doing some like outdoor activities, but those are pretty limited. After about 6 weeks, patients can really advance. The earliest typically is about 4 weeks getting into shoes, but I would say on average about 6 weeks. There's always inherent risk to surgery in regards to anesthesia and any open procedure. With hammer toes, the recurrence risk is there, but has become less as the technology has improved, fortunately. Swelling is one of the biggest things we fight in toes. Gravity, we just see a lot of swelling, and that can occur for quite some time, sometimes swelling up to a year or more off and on. First 6 weeks to 3 months, the most swelling. Blood flow shutting down would be very rare. If we think you're at risk for this, we would get blood flow studies early on to prove that you can heal and have adequate perfusion. If we had an issue where you're diabetic or had neuropathy or other vascular conditions, we would advise the conservative measures, make sure we don't wrap around the toes, we don't want to cut off blood flow, and our surgeries may be a little bit limited to more of a minimal invasive approach done through poke holes instead of more open procedures. Or we may be non-operative and have to do the custom shoes and shoe changes as well. But beyond the risk of normal surgery risk, which would be reviewed by the doctor in the office, there's not a lot of risk and frankly not a lot of downtime associated. Hammer toes can recur, particularly if we do a procedure called an arthroplasty or where we're trying to save the joint. We're doing our best to balance out the tendons at that time, but there can be an overpowering force of tightness in other muscles in the foot or the calf and lead to the toes contracting again. Certainly another injury could lead to that as well. This is why we lend more towards waiting until this is fairly severe and intervening surgically for fusions, or what we call arthrodesis, putting the two knuckles in the toe or the joints in the toe together permanently so that it cannot recur. Certainly you could have drift of the toes depending on the joint where the toes meet the foot if there's an injury there, but usually that should be addressed at the time of surgery and known ahead that there's other deformities leading to this. So we do see recurrence in hammer toes, but as technology's improved, procedure selection's improved, addressing the other issues with the foot, we see this less and less.